So this is data that is sort of referencing some of our earlier work where we use MRD as a means to understand disease response to transplant. So, because in myeloma these days patients are doing very well, living longer, progression-free and overall survival are endpoints that take years to measure, to really fully capture the essence of therapy. But that can quickly be understood, we think, with the use of measurable or minimal residual disease, wherein we can use MRD to assess the effect of an intervention. So what we've done is assess patients prior to transplant with MRD and then assessed it about 60 to 100 days post-transplant to see what is the depth of response in terms of MRD with transplant. So that's the premise. Building on some of our work that we did earlier and looking at the master clinical trial data, now we've pooled additional patients who have been treated as standard of care to fully understand how transplant benefits patients. So what we continue to see is that with autologous stem cell transplant, there is a median 1.15 log reduction in the MRD burden. And a bulk of this benefit is really present in patients with high-risk cytogenetics. So those patients derive a deeper benefit from autologous transplant, similar to data we've seen from the Stamina and other studies. We also looked into whether CD38 monoclonal antibodies used in induction have will affect our response with transplant, as well as Melphalan dosing. And both of these, at least in this study so far, have not shown to have any significance on how much. So it appears that transplant is an independent therapy that is still associated with a similar benefit regardless of what you get in induction, and we can achieve about a 1 log reduction when we employ transplant, regardless of what they received for induction therapy.